Thank you very much for the invitation to speak today. So you can see there my titles. That gives you my credentials and why it's okay for me to speak to you. I want everybody to get kind of relaxed because we're going to get into about a 40 to 50 minute talk about serious coding. It's going to be really exciting and it's going to keep you riveted. Actually, that's not at all what the goal for today is. The goal for today is to give you some basic ideas about what coding is all about. I can tell you when we talked about niches, that Sage's Ruck Advisor, that had nothing to do on my radar as far as my niche for this organization when I joined it back in 2003. And I will tell you that the benefit is, as I found it to be a very rewarding aspect. I'm thanked routinely about doing this for our organization. The benefit is I find it entertaining and exciting, and I do it on a daily basis. All of you will have to do it on a daily basis as well, and you're going to hate it. And that's the one drawback of this entire topic. So I do have some disclosures which will not impact what I'm about to talk about at all. So this is something that came directly out of one of my senior surgeons' mouths not more than a month ago when I was explaining to him about why he was getting a note from our coder about his specific methodology for coding for a specific procedure. The reality, of course, is, as you just heard from Dr. Mason, is that you need to know this. And you need to know it because, as Dr. Renton just said, this is how you're going to get paid, period. So I'm going to give you some basic ideas, a little bit about best practices as well, and we're going to talk about different coding sets. We're going to talk a little bit about billing, and then very briefly some pearls and pitfalls. You saw a similar slide in the previous talk about this, but it involved the entire patient interaction, which included the office visit and the back office. This is just the back office. This comes from a publication from JAMA earlier this year, and it shows the number of different groups that touch your paperwork or your patient billing between the time that you submit a claim and the time that it is eventually paid. It is a significant number of people, and so you can imagine that there's a lot of opportunity for error, and you need to be aware of this as you move forward. Here are 6 common coding methodologies that are used. Now, the bottom one is the one that most people understand because this is the one that we typically enter after we're completing a patient interaction or after we're completing a procedure. But if you are working in a hospital, your hospital is also going to be interested in all 4 of the previous codes because that is how they get paid, and that is important to them. And if you are an employed physician of that hospital, it's helpful to understand that concept. So what is the SNOMED CT methodology? It is about a 15 to 18-year-old system that is commonly used by hospitals to reference certain types of interactions between patients and their physicians. And you can see that it's not just used here in the United States, it's used across the world, and there are a significant type of relationships, over 1 million, that can be linked between concepts using this system. These types of codes are commonly used to also represent procedures by hospitals when they interact with insurers. The other type of coding methodology that's commonly used between hospitals and insurers is what is referred to as HCPCS codes. And these use CPT codes, but they embellish upon them as well. And these are commonly also diagnostic codes that are used to represent the reasons for a hospital stay. For example, you probably now enter or search a code for a disease in some sort of search mechanism within your electronic health record. You might search acute cholecystitis. That will find typically a HCPCS code to enter as the diagnosis rather than an ICD-10 code because that's more impactful for the hospital than necessarily the ICD-10 code is. And then finally, the ICD-10 code. ICD has been around for a long time. Most of you in the audience don't even realize that there was an ICD-9 that was used for 30 years, and that the people that have presented today had to go through a relatively significant transition in 2015, where you went from one form of communication to another form of communication, where the number of words in that communication multiplied by at least 4, if not 5. A very complex change that occurred only 2.5 years ago. And then finally, diagnosis-related groups. And this is really what hospitals are most interested in, and this is how they are paid. Basically, when you perform a procedure, it is grouped into a larger group of similar procedures. Gallbladders are grouped into the same as partial hepatectomies, as actually are grouped into the same group as liver-directed therapy for cancer, where an interventional radiologist will inject a material into the hepatic artery. All of those are in the same diagnosis-related group. The hospital will end up getting paid similarly for each one of those unless there are specific carve-outs. What's important is that every time you say that the patient is sicker than the typical patient, you will increase what the hospital gets paid. So if you say that that patient had hypertension, now that increases the level of complexity. If you say that that patient had hypertension and uncontrolled diabetes, now it's even more complex, and the hospital is going to get paid even more for the care of that patient. And you can imagine that they would be very interested in you being effective at using that terminology. And then finally, probably what most people are most interested in discussing is CPT code, because this is what directly impacts our individual take-home pay. And these codes are used to reference the interactions that we as physicians have with our patients, whether it's a clinic visit or an operative procedure. And as you can see, they've been around for a while and have gone through multiple modifications as well. How do CPT codes develop? So CPT codes are owned by the American Medical Association, and they own it because they make about $100 million a year on the CPT code hierarchy and methodology, whether it's through purchasing of books or through purchasing of software access for various vendors. The editorial panel has 17 members, and these 17 members are ultimately responsible for deciding what is a CPT code, what is worthy of becoming a CPT code. Members of SAGES, specifically actually Dr. Roth, one of our previous speakers, is on the advisory committee, and those individuals will speak in front of the CPT code panel in favor or against different proposals for CPT codes. But there's very specific types of codes that are available. The one that we typically use in the operating room is a Category 1 code. That's usually a mainstream procedure, something that we commonly perform, something that would definitely be considered non-experimental. That would be Category 1 code. The only other code that we would potentially use would be a Category 3 code. And unfortunately, those were intended to be areas for expanding or emerging technology, but what it has become commonly considered is experimental, and as a result, it's not commonly paid. So the types of codes that we use in the CPT hierarchy include procedure codes and E&M, or evaluation and management codes. Very briefly, evaluation and management codes are the most complex codes that you could possibly have to learn. The reality, of course, is that every time that you write a note, it's possible to read that note and understand the note differently depending upon how you interpret certain words within that particular note. So there are some basics that you can rely upon, and there are 5 major components of an evaluation and management code. They're the 5 major components of every note that you would expect to write. And as you can see there, there's a checklist. And fortunately, our organization has made some cards for us, and I would be happy to provide a copy of these to anybody who's interested. These are broken out. This is actually not the entire surface of the card. This is only the upper surface of the card. And it highlights history and physical exam. And as you can see there, it talks about different elements of the history. And depending upon the number of elements within the history that you are able to identify, you can check off a more complex assessment, from problem-focused to expanded problem-focused to detailed to comprehensive. And a similar effort can be initiated for the review of systems and for the physical exam, and all of these will impact paying. Finally, at the bottom includes the medical decision-making. And most surgeons think that when you decide to take somebody to the operating room, that automatically justifies the highest level of decision-making. And the reality is, the answer to that is no. If you offer to take a straightforward inguinal hernia repair patient to the operating room, that would typically offer you, at most, a medium level of decision-making. So when you put all of these things together, you end up having this pattern where you may fulfill certain aspects of documentation within your note and other aspects where you're not quite fulfilling that documentation need. Ultimately, the lowest level of documentation is what justifies your level of coding for that particular interaction. And you can see here all of the different methods in which you could have different levels of coding and what they ultimately justify in the end. Interestingly enough, your practice can follow how you commonly code. And if you look back here, it's a little dated, but you can see my coding practices on different groups of evaluation and management codes over the course of a one-year period of time, from 2012, or a two-year period of time from 2012 to 2013. And what you can see is that they actually have normative data for a very large faculty-based program. That's what the FPSC involves. It is a corporation that collects all of a large group of faculty-based practices together, and it creates normative data for utilization of these codes. If you fall outside of this normative data, that will raise a flag to different payers that you may be using the codes inappropriately, and it may initiate an audit. So what you want to be here is not a zebra. You don't want to be somebody that stands out. You want to be part of the fold. You want to bill just like everybody around you is billing. Procedural codes are a little bit more important because this is how we really get the bang for the buck with regard to our coding methodology. You have to remember that they're aimed at the typical patient. I understand that the cholecystectomy that you performed at 11 o'clock at night that required an intraoperative cholangiogram that took you 3 hours was incredibly painful. You're going to get the same RVUs for that you will for the biliary dyskinesia that took you 30 minutes at 9 o'clock in the morning. Fortunately, it actually in the books says it's going to take you 80 minutes to perform that cholecystectomy. So if it took you 30, you're getting extra money. Now, what do I liken this to? If you take your car to a mechanic, the mechanic typically at a reputable repair location will refer to an SAE guideline that says, in this car of this year, it should take 2 hours to fix the distributor cap. And they'll charge you 2 hours worth of work. Now, if they're a really good mechanic, they may finish it in an hour, but they're still justified to bill you 2 hours. And that's the same for us. If you're an efficient, safe surgeon, you still get to collect the same amount, even if your partner takes a little bit longer and has the same outcomes, you get paid the same amount. One last item there on that. You have to understand that when you perform a procedure, sometimes the time of work that's involved with that extends past the actual procedure. So you may be responsible for the entire care of that patient for the following 90 days because the global period involves that period of time. That is different from one code to the next, You have to understand that you won't necessarily be able to collect additional billing after you perform the initial procedure. As we go into billing, we have to understand the most important term, and you've heard it several times today, relative value unit. That comes from a methodology that was initiated in the 1980s and has been used routinely by Medicare since the early 1990s. The amount of work that is used to perform a surgical procedure and is measured into the CPT code involves not only the work that is done from cutting to closing, but also the work on the day of the procedure and the work the day after the procedure, or as many as 90 days after the procedure. Your practice gets more than just your work, though. There are other elements that are cooked into the RVU code system. There's part to support your practice, and there's part to support malpractice. And all of these are added together to a total RVU. It's multiplied by what is referred to as a geographic factor that is used to adjust payment for different areas of the country having a different wage index. It's much more expensive to live and work in San Francisco than it is to live and work in Indianapolis, Indiana, and as a result, you get paid differently depending upon where you are in the country. Finally, as far as the CPT code methodology is concerned, there are modifiers, and the appropriate use of modifiers can be very helpful in improving your coding methodology. You use the 51 modifier when you're performing multiple procedures. In this circumstance, the first procedure, you'll get 100% of the RVUs for that code. In the second procedure, you'll get 50%, and every procedure after that, for CMS, you'll get 50%. For some private payers, you may get 25%. It's helpful to know how your institution is going to pay you when you do multiple procedures at the same time. Do they follow CMS rules, or do they follow alternate rules? There's different coding modifiers if you perform procedures at the same time or at different locations at the same time, whether it be on both sides of the body or just on one side of the body. There's coding modifiers that are used in circumstances where you have a first assistant. They also get RVUs if you appropriately justify it, if you have a co-surgeon, or if you are performing a procedure that is particularly complex, that necessitates an extra amount of time, you may be able to use the 22 modifier to increase your pay. There are specific teaching physician rules that you need to be aware of if you are working in this environment. And it has to do with attestation. For most of you, you are probably well familiar of this. It requires specific timely documentation. Students have historically not been able to be used their documentation, but that is now actually one of the things that has changed in the last month. Documentation of medical students can now be used to document in the medical record, and you can actually use it to support your billing. Some pearls and pitfalls of coding. So, like I said, you need to be aware of how to code. You need to learn this. I think as Dr. Mason said, you should attend a coding course yourself early on in practice. You should meet with your coder. Your coder should understand and learn how you describe procedures in your operative summaries. They will be able to give you specific guidelines in the words that you use that can help support additional payment or additional codes. You should also continue to meet with them on a relatively regular basis to make sure that there's no changes that you need to be aware of. You should understand how they end up coding. How do they look at the operative summary? What do they review? You shouldn't rely upon them completely because many of them have actually a high school education and an associate's degree. They are not necessarily experts. You have to become the expert. And be aware of the potential that when you use one code a lot of times, especially in E&M coding, that you could lead to an audit. And in these circumstances, many times it's initially an internal audit from your hospital. If they ask to look at your codes, don't become angry. They're trying to protect you. They're trying to make sure that you don't expose yourself to an audit from a payer like Medicare. And then final slide, with regard to billing, don't neglect the fact that you should use your E&M coding to support your consults in the hospital. Up to 10% of your take-home pay can come from seeing patients in the hospital, and many of the surgeons in my practice do a poor job of fulfilling and entering that bill. You should understand the relationship between your coders and billers and you and your institution. Do they have a stake? Many do. If you hire a private coder, they typically will take 5% of your collections as their pay. That's a standard fee. Now, if your coders are employed by your hospital, they may also take 5% from your take-home pay, but they don't have the same interest that the private one does because they're also doing inpatient coding at the same time. And whether you get paid $600 for your cholecystectomy or the hospital get paid $12,000 for the cholecystectomy, you can immediately see who or what code they're going to rely upon. And then I won't go into each of the specific numbers there at the very bottom, but those are all areas of finance that Dr. Mason briefly touched on that you need to be aware of and to evaluate on a regular basis with your coder and your biller. How much of your bills are still in accounts receivable at 90 days? How many have been denied? How long is it taking to get a code or a bill in? And what's your payer mix? All of these will impact your take-home pay. Whether or not you're in private practice or in a hospital, all of them will impact your take-home pay. If not now, they eventually will. Thank you.